And record. Get back to my slides. Okay, I think that's everything. You know, I've done a bunch of these live stream videos and I still always second guess myself if I'm doing it correctly or not, but so far so good, I believe. So welcome to the second session of our 2020 virtual breast cancer survivor symposium. This actually would have been the date that we had our in-person event. So very sad that we weren't able to meet in person, but very happy to have the few of you who could join us today on the call. This will be recorded, so if you know someone who couldn't come or had a scheduling conflict, we will have the information available. So I am Gina Chicatel, the Associate Director for Susan G. Komen, Northeast Ohio. This is one of my favorite events, but before we hand things over to our presenter, I want to go over a few housekeeping items. For those of you on the call who aren't presenting, if you could please keep your phone lines muted. That way we can make sure that we're eliminating any background noise that could be a distraction. Also, if you are able to switch your screen into speaker view, that way you will be able to see the people who are speaking rather than everyone else on camera. That would be great too. You can ask questions at any point during the presentation by utilizing the chat box, which can be found at the bottom of your screen in the control panel. So we'll have a time for Q&A at the end of the presentation, but if you have a question, don't want to forget what it is, go ahead and write it down in the chat box. I will be monitoring those and letting Dr. Gulotta know what those questions are once her presentation is wrapped up. Again, this is live streaming on Facebook and we are recording it. The recording should be placed on our website within 24 hours. So you can go to coleman.neohio.org/survivor symposium to get a link to the recording. We will also post it on YouTube as well as Facebook. So again, if you ever want to come back and revisit this information, you absolutely have that opportunity to do so. We are talking today about advances in breast cancer research. So I just wanted to touch on some of the great things that Komen has done in the research space. So since 1982, when Komen began as an organization, we have invested more than $1.1 billion specifically into breast cancer research. We are the largest nonprofit funder of breast cancer research. We are not the top funder. The federal government is the top funder of breast cancer research, but we are second to them. And that 1.1 billion has funded more than 2,700 clinical trial or 2,700 research grants and more than 500 clinical trials. So because of medical research, improvements have been made to early detection and the treatment of cancer that have led to a 40% decrease in breast cancer mortality over the last 30 years. So since Komen has started, we've seen a 40% decrease in mortality. There are more than 3.8 million survivors in the US, but despite this tremendous progress, more than 42,000 women and men will still die from this disease every year in the US, and we believe we can do better. So our research investments are guided by more than 40 leading scientists and advocates, including our scientific advisory board and Komen scholars. It should also be noted that we have a panel of patient advocates that help direct our research funding. So we do have survivors that help us make decisions as to where our research dollars should go. And our research program is patient focused. So they are involved in every step of the research project or process. I'm going to drop a link here, hopefully. I will at some point in the chat box, a link to a page on Komen's website where you can get all of the information for the currently funded research grants. But you can see here the breakdown, and this is since 1982, of where our research investment has been directed. So a lot has gone into treatment, biology, and early detection and prognosis. We also look at the causes of breast cancer, prevention, which I believe prevention and causes of breast cancer go hand in hand because you can't prevent something until you know what causes it. And as of to date, we do not know what causes breast cancer to develop. So I think those go hand in hand. And then we've done some investment in survivorship outcomes. So what are Coleman-funded researchers doing now? Of course, we listened to our patient advocates and worked with our scientific advisors to set our research priorities to help us achieve our mission of eliminating breast cancer forever. So right now we're looking at new and improved treatments specifically for metastatic breast cancer patients, starting with understanding how the biology of breast cancer spreads. We're also developing better treatments for more aggressive forms of breast cancer, like triple negative breast cancer, that tend to become resistant to therapy and tend to be more metastatic than other types of breast cancer. We're also looking at identifying the factors that contribute to breast cancer disparities. So what is causing this racial gap between African-American women and some Hispanic women versus white women who tend to have better outcomes than their African-American counterparts. And we're also making an investment in big data and transformative technology, such as AI, that will help fuel scientific discoveries, accelerate the delivery of equitable patient-focused care. We also have a series of research fast facts on Coleman.org. So you can see I pulled a screenshot of the complementary medicine and integrative therapies fast facts. So this one sheet will go over all of the investments we've made into these specific types of research. There is a fast fact for almost everything you could possibly imagine. I will again drop the link to that in the comments or the chat box once I stop speaking. But we have information on clinical trials, metastatic breast cancer, triple negative breast cancer, HER2 breast cancer. So if you know your specific type of breast cancer tumor, we definitely would have a research fast fact sheet about that, so you can look at where our investment has gone for the current year. So in Ohio specifically, Coleman dollars have definitely come back to our community. We currently have 3 active research grants. I believe 2 are in Columbus and 1 is in Cincinnati at the moment. We have funded UH. We have funded the Cleveland Clinic. I believe the last grant that came to our service area was Altman Hospital in the Canton area. Overall, they've funded 52 research grants at $14.3 million, and we funded 25 early career investigators in the state of Ohio. So with that, I will turn everything over to today's speaker, Dr. Christina Gulotta, who is sort of new to Summa Health, but definitely not new to the Northeast Ohio area. She was actually born and raised in Northeast Ohio. So we are very, very happy to have her here with us today. I'm going to stop sharing my slides so she can take over. So Dr. Gulotta, it is yours.
Thank you so much, Gina. I'm going to try to be as technologically proficient as you are. Let's see if I can do it. Okay. Just trying to pull up my slides here. All righty. Are we seeing some slides up there?
Not yet. Did you hit the share screen button? Oh,
is it coming through?
There it is.
Okay. Good. All right. Well, good afternoon, everyone. Thanks for the nice introduction, Gina. Yes, my name is Christina Gulotta. I am currently at Summa Breast Center, but I am from the Akron area, born and raised, actually born at Summa. So it's kind of full circle for me. So that's what I wasn't sure if there was video, so I wanted to put a face to a name for anyone watching from home. And I had to give a shout out in the Northeast Ohio area to anyone watching who's also a Hoban Knight. That was my high school. So I was here for, born and raised, and then went away for my college and medical training, and very happy and lucky to be back home. With this chat, I have no disclosures to report. And I do want to also make a little announcement here that I don't know if you can see my little pointer here, but in case there's questions or any comments, I have put numbers on the slides here at the bottom, so that if you want to go specifically back to a certain slide, we can do that. Okay. So when I first heard the topic for today's talk, I was like, oh my goodness, that's a very broad topic. It's so much going on in the field of breast cancer research. And as Gina mentioned, it's in survivorship, it's in prevention, it's in treatment, it's in causes. So, you know, I tried to look at some things that I thought might be the most interesting to you ladies and to our community, and stuff that's been in the media lately, of course, and some current ongoing trials and updates in treatment care. So to break it down, the things that I'm looking at, you know, starting with everybody's favorite COVID and the current effect that the pandemic is unfortunately having on breast cancer screening and diagnosis. And then looking at results from enhanced recovery protocols. Anyone who's gone through breast surgery may be kind of familiar with these terms. It's something that's very commonly used in breast cancer surgeries now and will continue to be the trend of the future. So I think it's important to be familiar with it and to know what it entails and why it's beneficial. And then we'll also look at lifestyle changes and their effects on both breast cancer and breast cancer risk. And this is really key because, of course, it's always great when there's something you can actually do. You know, can't really affect genetics, but this is something that we can actually make an impact upon. And then finally, I wanted to look at DCIS, or non-invasive stage 0 breast cancer, and talk a little bit about some of the current research that's going on regarding if observation is safe at this point for that type of cancer. So before I started, I just wanted to kind of do a very brief overview of breast cancer care in general and some breast cancer facts. I mean, it's always astounding to me that until the 70s, you know, breast cancer treatment was so overly aggressive, and that, you know, we poor women had to go through these very aggressive surgeries and treatments without, you know, the kind of results that we can have today for quality of life. So, you know, this is here radical mastectomy. And then here now you can see we can achieve such better cosmetic results, even able to, you know, preserve the actual tattoo here. Everything is lined up perfectly with a great cosmetic and comfortable functional result so that you can go on living the rest of your life as normally as possible. So some facts that you may be aware of, but that you may also want to kind of put in your mind bank and share with family and friends, especially in this month of October. Currently, the average risk of a woman in the US to develop breast cancer in her life is about 13%. So about 1 in 8 is what that translates to. And of course, that's 7 in 8 that you won't have the disease. Now, breast cancer, again, as you probably know, is a second leading cause of cancer death in women after lung cancer. And the chance that one could die from breast cancer is about 1 in 38, which seems small, but is significant. Since 2007, breast cancer death rates in the US have been about steady in women that are younger than 50, but have fortunately decreased in older women. And so that death rate up until about 2017 so far has decreased by 1.3% per year. And what we think is causing a lot of this decrease in the death rate is really early detection. So aggressive screening and increased awareness of breast health. Of course, and we have better treatments as well. So here, screening really translates into early detection, which really translates into survival. And so here, this is really the key point of this page, is that, as you can see here, when we look at 5-year relative survival rates in stage 0 and 1 breast cancers, that number is way over 90%, close to 100%. And then as we go at more advanced stages of cancer, we see that that number drops off. It's the second most common cause of cancer in women after skin cancer, and second leading overall cause of death in women, first being heart disease. So of course, our goal is to find this breast cancer before it starts causing symptoms. And that brings us again to everybody's favorite COVID-19. This has had, of course, a huge impact on, I mean, not just breast cancer care, breast cancer screening, but our overall lives. And it's incredibly depressing in general. But to specifically parse it down and look at its effect on breast cancer, we know that early in the course of the pandemic, the American Society of Clinical Oncology put out this statement regarding COVID-19 and cancer screening. And so what they recommended was that to conserve health system resources and reduce patient contact with healthcare facilities, cancer screening procedures that require clinic or center visits, such as screening mammograms and colonoscopies, should be postponed for the time being. So that was the official recommendation. However, unfortunately, as a result of that, we do see some pretty significant effects. This study from JAMA, the Journal of the American Medical Association, is entitled Changes in the Number of US Patients with Newly Identified Cancer Before and During the Coronavirus Disease Pandemic. And unfortunately, when the researchers in this paper looked at the weekly numbers of new diagnoses for 6 common cancers, breast cancer included, they found that the new diagnosis dropped 46% in 2020 compared to the same time in March and April, rather, compared to 2 months prior to that in January and February. And unfortunately, breast cancer diagnoses declined the most. That was about 52%, and that's likely due to the decrease in screening. They also found similar trends in other nations. So, we're not the only ones, of course, what's going on dealing with this issue, trying to find a way to survive life in the pandemic. But in the Netherlands, the Cancer Registry reported a 40% decline in weekly cancer incidence. And similarly, in the United Kingdom, they found a 75% decline in referrals for suspected cancer since they started all of their COVID regulations. Another article out of the Journal of Clinical Oncology looked at data from 20 different institutions within the United States, and they compared the first 4 months of 2020 to the first 4 months of 2019. And unfortunately, what they found too is that breast cancer screenings were down by this, astronomical number, 89%. And similarly, that colorectal screenings were down 85%. This study also found that overall clinical encounters for breast cancer patients decreased by 48% in the first 4 months of 2020 compared with the first 4 months of 2019. So some really, really unfortunate data, and we're just anticipating that this will lead to some more advanced disease when it is found. And here, I love this quote here: "The only thing we have to fear is fear itself." So the only thing you have to really be afraid of is if you don't get your mammogram. So, as survivors and, people who are so well versed in breast cancer care, it's, if you can help us all be advocates for your family and friends and for everyone as a whole to be proactive in getting mammograms. I can speak for Summa and for Akron General, where I did my fellowship, that everyone is taking the utmost precautions. So if you can encourage everyone to not neglect this important piece of preventative care, at this point, these services are being offered and they are up and running. And, switching gears a little bit. So talking first, we talked a little bit about prevention, COVID's effect on screening and early detection, to talking about once there is a diagnosis of cancer and someone makes a surgical decision, what can we do to make that process the best it can be and to make sure that it's seamless for the patient? And so that brings us to enhanced recovery protocols in breast cancer surgery. So the question is, why do we even start to look at this problem? And as you know, the opioid crisis in the US is a huge issue, particularly in our area. But nationally, 128 people die every day from an opioid overdose, as far as data collected in 2018. Also leads to huge financial losses. The estimated economic burden of prescription opioid misuse is a number that I can't even fathom, but it's $78 billion a year. And unfortunately, another consequence there is that the substance abuse of opioids is going to affect 1.7 million Americans. And as I alluded to before, in the Midwest, we have seen a huge problem with the opioid epidemic, 70% increase in opioid overdoses from July 2016 to September 2017. So definitely a good reason for these enhanced recovery protocols to have come about in the first place. Again, just kind of staggering numbers. If you look in 2017, 70,000 drug overdose deaths, and 2/3 of those involved opioids. In 2018, there was a bit of a trend toward a decline, about 4.1%, but again, still a huge proportion involving opioids. So then in the next phase, that was kind of 2016, 2017, looking from 2017 to 2018, we saw some good trends. We saw opioid-involved death rates decreasing among females, a younger population, non-Hispanic whites, and in areas that were small, metro, micropolitan, and non-core, and in the Midwest and the South. So that number to a total decrease in prescription opioid-involved death by about 13%. And fortunately, that largest relative decrease occurred in Ohio. So go Ohio. And the question is, how did we even get to the point of these staggering numbers? And a lot of it is stuff that we do as surgeons and doctors during surgery. Prescription opioids are very commonly and have been historically very commonly prescribed. 21 to 29% of patients, though, who are prescribed opioids for chronic pain can misuse them, and they can go on to an opioid use disorder. What we know is that sales of oxycodone and methadone have quadrupled in the last 2 decades. And the number of filled opioid prescriptions really did peak in 2012. So now we're kind of dealing with the back end of the problem, trying to recognize it and rectify what we can. And that leads us to these enhanced recovery after surgery protocols. So these are basically evidence-based care elements that are probably, you may have heard them, if you haven't heard of them in breast surgery, you may have heard of them with regard to colon cancer surgery, to reduce morbidity, length of stay, improve patients' overall survival. So very important goals, and definitely something that should and is applied to breast surgery. So actually there is an Enhanced Recovery After Surgery Society, and in 2015 they developed some guidelines to help apply these same principles to breast oncology. And what they looked at was a whole bunch of data, some of which I'll go over here because it is helpful to kind of put it together by lumpectomy, mastectomy, and kind of identify where it's useful. And they came up with some consensus recommendations. And so I won't belabor the points too long because this is a big overall topic and I want to get to a lot of things, but I will briefly touch upon them. So overall, they talk about the importance of pre-admission information, education, and counseling. It's something that I'll echo in the American Society of Breast Surgeons' recent consensus recommendations as well. And it's really important to just be honest ahead of time about what a surgery may feel like, what the recovery process is like, and set reasonable goals and expectations. Of course, there's also prehabilitation and pre-admission opportunities that we can take for, reducing smoking and smoking cessation to kind of reduce any healing issues, alcohol use, etc. For individuals who are having perforator flap planning with their plastic surgery teams, depending on, which plastic surgeon, what their practices are, they may want to do this special CAT scan mapping to look at the blood supply. Minimizing any perioperative fasting and things that kind of alter our metabolic milieu too much. Also giving preoperative carbohydrate loading was something that they felt had pretty moderate evidence. Of course, preventing blood clots like we do really in most surgeries. Antibiotic prophylaxis, so of course minimizing the risk of infection that can also prolong a hospital stay, lead to an infection, etc. Really minimizing postoperative nausea and vomiting, and thinking of it in terms of a prophylactic preemptive way. So even in the preoperative area, thinking of, oh, can I, put a little scopolamine patch on this patient so they wake up and they don't have the effect of any, micro doses of opioids we may have had to give for pain control in the OR. Preoperative and intraoperative analgesia. So the key here is really a multimodal approach using many different kinds of medications, oral, through the IV, through injections with blocks, Some of these include medications like gabapentin, your NSAIDs like celecoxib or ibuprofen, various anesthetics that can be injected into the pectoral muscles like bupivacaine, magnesium even, venlafaxine, clonidine, a lot of different options, which is great because then we can really pinpoint and target this very well for each particular patient. Various differences in anesthetic protocol that kind of vary from hospital to hospital. Making sure that in the OR, your temperature stays nice and warm, that there's no hypothermia that occurs, which the ORs are chilly, as anyone who's been in an OR knows. So that's a very key part of our operative plan. Of course, making sure that you're very, very well resuscitated, that your electrolytes are in check in the OR is key. And then post-operatively, again, using that same multimodal pain regimen that really minimizes opioids. But of course, if there is excessive pain to the point where it's not hit by the other methods that we've tried, definitely not hesitating to use opioids when necessary. Of course, early feeding. Most of you from experience know, kind of as soon as you feel your stomach feels settled, start to eat right away. Post-operative flat monitoring, of course, and this depends again based on the institution. So some do have the implantable Doppler devices versus just clinical evaluation and examination. Keeping an eye on the wounds. This is kind of specifically more applied to complex wounds when perhaps wound vacs may be applied. Early mobilization, which I kind of get into a little bit along with my next slide here, talking about early physical therapy. And I'll talk further in the talk, the key importance of on post-operative day one, that first day that you wake up after surgery, you're sore, but that's the time to start mobilizing and especially doing arm exercises, making sure that you walk and doing other things that are going to be so helpful in the overall recovery process. And so for us, the question is, well, where did we get the information that this is even helpful, that this is even going to be good, or are we just, shooting ourselves in the foot by not giving pain medications? Well, we are giving pain medications, but we found that the ones that we can give are better than the opioids, and here's how. So first, we looked at flap reconstructions, and this is a great study out of the Mayo Clinic from 2015. And what they did there was they split 100 patients between the traditional route of their protocols of anesthetics, and they used the enhanced recovery after surgery protocols. And what they found was a lot of good things. They found their mean length of stay was significantly shorter with the enhanced recovery protocol than the traditional protocol, and that the total inpatient opioid consumption was much less for the enhanced recovery than for the traditional methods. And even with that reduction in opioids, complications were unchanged. So this was incredibly important. I mean, this is, you can get back to your own bed. You're not having the nausea that you can have with opioids, constipation you can have with opioids, and other, of course, more serious concerns in terms of, a lot of patients are concerned for, developing addictions and things like that. So this was a wonderful study that showed that this is actually a great alternative that we can start to employ more frequently. So their protocol is really similar to some of the guidelines that I've already showed. Again, a lot of pre-admission counseling, using the special pain medications even before the operating room. Again, Tylenol, gabapentin, and kind of those NSAIDs, the Motrin are good ones to use. Maintaining the adequate resuscitation in the OR and maintaining normal temperature. And here they have, and what you may have heard is this liposomal bupivacaine. So another word for this is Exparel. So you may have heard this. It's a nice block. It's quite long acting, and sometimes that can really help get over that first few day hump. Post-operatively, again, using early mobilization and using a variety of pain medications is really key. Similarly, out of Georgetown, just in 2019, researchers there took a look at the specific use of gabapentin as a pain medication. And they wanted to kind of parse apart its effects on patients in the recovery process. So preoperatively, they did a lot of the similar things that we've talked about. They use the scopolamine patch to minimize any of that nausea, vomiting, Tylenol, gabapentin, the celecoxib, and again, that preoperative counseling that's so key so that everyone's on the same page. Intraoperatively, again, using a variety of pain medications, minimizing any narcotics in the OR too, and again, normal temperature, preventing blood clots. Postoperatively, again, the key is the mobilization and using a variety of pain meds, but without, of course, neglecting any pain that really does require an opioid for breakthrough pain. And so what they found was that once they implemented this protocol at Georgetown, they use the word here MME for morphine multi-equivalence, but they found what it generally means is that the opioids that were consumed by the patients were reduced. So that decreased 85% during the implementation of this process that they used. And they also found that their average pain scores and even the nausea medications they gave decreased. And they kind of, they quantified these numbers here, 59.8 milligram decrease in post-op opioids, 21% decrease in pain, and about 2.5 fewer doses of anti-nausea medications. The only thing that they did find with the gabapentin is an increased time to ambulation by 0.9 days. So sometimes folks did feel a little more not as steady on their feet with the gabapentin. That was the only sort of downside there. And also they found, again, postoperative Tylenol was very useful. It also had a significant decrease in postoperative pain. So those are flat-based reconstructions, and now we know that it's also useful in mastectomies with implant-based reconstructions. So this study out of the University of Pennsylvania, also just a couple years ago, or actually last year, feels like this year has been 3 years, but it's only been 1 year. So this study out of the University of Pennsylvania looked at their implementation of an enhanced recovery protocol and overall narcotic requirements and a length of stay. So what they did was they took 23 patients that they planned for a mastectomy with an implant reconstruction, and then they compared them to patients they had previously operated on that had, of course, used what they had done in the past, that traditional recovery protocol. And they looked at the effect of gabapentin, Tylenol, and those NSAIDs that we had talked about. And again, they found significantly fewer narcotics were required over the first postoperative days 1 and 2, a significantly shorter mean length of hospital stay. In this case, they found equivalent pain scores, and importantly, they also found equivalent post-op complication rates. So the fact that they minimized the opioids did not increase any negative outcomes in these patients. Again, out of China, they had a huge kind of analysis of multiple different studies that, again, almost 2,000 patients here that showed that with the implementation of these enhanced recovery protocols, patients had a significantly decreased length of stay. They could go home to their own bed sooner, less morphine administration or general opioid administration, and decreased pain scores as well. So they were actually feeling better at home sooner, didn't have to take these medications that could have these negative side effects. Another great review is showing the meta-analysis of post-mastectomy breast reconstruction cases. A lot of these are autologous flaps, and essentially, again, the key here is that the enhanced recovery protocol reduced opioid use and length of stay versus traditional care, and they didn't have an increase in complications. It was roughly about the same. And then finally, looking at lumpectomies, obviously not as intense, or I should say extensive of an operation as a mastectomy or a flat-based reconstruction, but definitely has its pain elements as well, and not something that we should neglect when we're thinking about all the good benefits of enhanced recovery protocols. So this study was an observational study for breast patients with and without cancer who were undergoing a lumpectomy. So of course, if the patients had, fibroadenoma or some other mass of some sort, and they were undergoing a lumpectomy, they were included. And what they found here is that the patients who had the enhanced recovery protocol had a statistically significant decrease in the number of pain meds that they were discharged with, and that the post-op pain scores were not statistically different, and they had all few complications overall with no difference. So very recently, the Annals of Surgical Ecology had a great article, again, kind of analyzing the trends within breast surgery of what breast surgeons are doing to modify their practices sort of in a national level on the basis of a lot of this recent research that I just mentioned. And so they surveyed breast surgeons, and in 2017, only about 23% reported using these non-opioid regimens, but that number shot way, way up in 2019 to 79%. So this ended up resulting in using about 40%, an adoption of non-opioid regimens for 40% of breast operations. And overall, fewer prescribed opiates. So in those cases where it really was necessary, it was prescribed, but again, at a very judicious level, and no increases in ED visits or readmissions for patients who had pain treated with this non-opioid regimen. So really key, important stuff. And that has subsequently led to the American Society of Breast Surgeons developing these overall consensus recommendations just this year in an article that came out. And again, they kind of divided, as you've seen the trend that I've described before, into the preoperative phase, the intraoperative phase, and the postoperative phase. And again, there's so many options, and it's such a great modality to use. I'm passionate about it. It's something I have done some research on as well. And in the preoperative phase, again, identifying patients, I'm sorry, little typo there, at increased risk for pain management problems, prehabilitation, like we talked about with the smoking cessation, et cetera, counseling and medications directly in the pre-op area that day of surgery, the Tylenol, NSAIDs, gabapentins, et cetera. Intraoperatively, using other pain medications apart from narcotics or fentanyl, et cetera, such as Tylenol, Toradol, Zofran, so getting ahead of any nausea. And in the postoperative phase, again, using the same kind of combinations of medications, using the oral versions of those as the discharge medications. And then, which is, I think, really great that they included this in their pain multimodality options, is alternative approaches. So exercise, education, guided imagery, music therapy, hypnosis, cognitive behavioral therapy, and mind-body medicine techniques. So they talk about the different data to support the utilization of those techniques for pain control in the post-op period as well. And similarly, ARIS and postoperative nausea, again, another great recent article just from 2020 was describing, I suppose it was out of California, out of Kaiser Permanente, the implementation of a protocol at a single institution. And, you know, a lot of the results we've seen have really focused on pain scores, going home sooner, but this study particularly looked at decreasing postoperative nausea and vomiting for patients who had a total mastectomy with and without reconstruction. And then similarly to the other studies that we've seen, they also found that this resulted in decreased overall opioid consumption without a compromise of patient pain control. Alrighty, so switching gears slightly, but again, it's all interwoven and all connected, is talking about physical activity, lifestyle changes, and things that we can do to mitigate risk and recurrence and improve survival. So this is a great study that just from 2020 that looked at physical activity before, during, and after chemotherapy for patients with high-risk breast cancer, and looked at their actual survival in relation to their amount of physical activity. So this was at multiple centers, and the investigators looked at how a patient's pre and post diagnosis physical activity was associated with their survival outcomes. They had a great, huge size of patients, 1,340 patients in what they called the Diet, Exercise, Lifestyle, and Cancer Prognosis Study. And what they did was they measured activity before diagnosis, during treatment, and then at 1 to 2 year intervals after the enrollment. And so they basically, the way they did it was they stratified this activity into these particular categories of inactive, low active, moderately active, which was the one that actually met the guidelines that are currently in place, the physical activity guidelines for Americans, And I want to say that's about 180 minutes of moderate exercise per week. But they delineate it very nicely in the paper. They kind of explain exactly what kind of targets hit each point. And then of course there's high active, that they could categorize patients into that group where they actually exceeded the guidelines. And so what they found is that the patients who were at that moderately active level where they just met the guidelines, both before and 1 year after diagnosis, actually had a statistically significant reduction in, they used in their statistical analysis, hazards of recurrence and mortality. But essentially, they had an association between increasing physical activity and decreasing their risk of recurrence and death. Really awesome stuff when you think about it. So that's something we can actually do easily. It's not even a pill that we take. This is like really exciting stuff. So similarly, for patients who have had a diagnosis, who have had a surgical intervention, the important thing too is range of motion exercises. So again, another aspect of physical activity. This study came out of Brazil. Physical therapists there did a really interesting study looking at early free range of motion upper limb exercises after mastectomy, and then also immediate implant-based reconstruction, and seeing if they're safe and beneficial. So pretty ingenious way she did this. 60 women who had breast cancer and were treated with mastectomy and implant tissue expander reconstruction were divided into 2 groups. But they first all initiated exercises with their shoulder range of motion limited to 90 degrees, again on that post-operative day 1. So all the ladies were doing this post-operative exercise. Then at 2 weeks, they were divided. And so one group of patients was called the free range group. They were permitted to do shoulder range exercises until they were limited by pain, or their official stop was wound dehiscence. So hopefully they stopped before the wound broke apart, but the pain was the limiting factor. But they were allowed to do full range of motion until they felt limited, and then they kind of had to listen to their body and slow down. And then the second group of 30 ladies were in the limited range group, and they were instructed to maintain that shoulder movement restriction at about 90 degrees until 30 days after surgery. And then at that point, they were also allowed to use free range of motion. So in terms of what they measured, the first thing they wanted to measure, of course, were, okay, is this going to increase complications? Is this a bad idea? And so they looked at the incidence and prevalence of, wounds coming apart, fluid collections, infections, necrosis, etc. Secondarily, they looked at shoulder range of motion, pain, and upper limb function. So really, how is this helping to be proactive, not what it's, causing in a negative aspect? What is it contributing to the patient? And what they found was that the free range group and the limited range group thankfully did not differ in these post-operative horrible complications here that we heard about, but that the free range group had less pain, greater shoulder amplitude, and better upper limb function than the limited range group. So really significant when you think about some of the pain syndromes that can be related just to the shoulder after surgery. So really great news there. Again, switching gears, another topic that is, we don't have complete answers yet, but it is something that's currently out there. So I did want to bring it up and mention it, is about observation. We usually want to be very proactive and, go the extra mile to avoid any complications from a cancer diagnosis. But a lot of folks have started looking at, is observation safe for that early stage 0 non-invasive cancer, also called DCIS, ductal carcinoma in situ. And so I did want to briefly touch upon these trials here for DCIS observation. Right now there's quite a few trials out there, Comet, Loris, and Lord. And the way that we have thought about DCIS has changed, historically quite a bit. Originally, it was thought as an expectant precursor to this, more invasive disease, the stage 1, 2, 3, 4 cancers that we treat. But what we've noticed is that many of these, these in situ lesions can be overtreated and could have otherwise remained non-invasive and subclinical with just active monitoring. So several trials are currently active to kind of see if this is a safe option. We have the COMET trial in the US. So this is a phase 3 randomized clinical trial, again, looking at observation versus surgery and standard treatment, standard care for the NCCN guidelines for DCIS. Similarly, our colleagues in Europe have the LORIS trial, another phase 3 randomized clinical trial looking at surgery versus observation. And then a British trial, but actually with multiple centers throughout Europe, is the LORD trial, again, evaluating the low risk elements of DCIS. And if they do better with surgery or surveillance, or if they're equivalent, if surveillance is safe. There's another trial out of Japan as well, the Loretta, that is looking at this very similar topic. So, it's something that we're looking forward to see if it is a safe option. And, as with everything in medicine, there's always particular qualifiers that will make someone eligible. Every DCIS is different. So one DCIS is not the other DCIS. There's always other features, grade of the disease, associated things in the pathology report that you can hear of, like commutonecrosis, et cetera. That's going to change your thinking about, well, should I observe or should I take this out? This looks a little more aggressive than this DCIS. So they're looking at that now, and hopefully that will lead us with some insight on what one of the main themes is for breast cancer treatment overall, which is really avoiding the overtreatment. We started with that first slide of, the radical mastectomies that we used to do in the past for breast cancer. And, it's really something that we need to consider with compassion for females who are going through this process. So we want to make sure that what we do, we need to do, and that we minimize subsequent effects on a happy, healthy life. So in conclusion here, we have come a long way. As I've mentioned, going from this to this is no small feat, and thank goodness that we've gotten to this point. However, we do have a long way to go. So these are some of the topics that, I always get in my inbox that are always floating around different breast conferences and that are really interesting and I hope useful to you. Again, it's really important for us to know how COVID-19, and is affecting, well, everything in our lives today, but, from the breast cancer perspective, how it's affecting screenings and cancer diagnoses. We want to make sure that that doesn't set us back after having come so far in early screening and early detection. And of course, looking at the enhanced recovery protocols and being really proponents and supporters of those protocols so that everybody has a more positive experience surgically, looking at the lifestyle changes that, we can make. I mean, this is, it's so great when there's something that's not something you have to take that's a pill. It's something that we can actively do to improve our survival or risk. And finally, of course, looking at these studies to make sure that, we don't go in the direction we were before where we overtreated everything, where we can really do just the right thing for a long and healthy life. So with that, since it is October, had to combine, October pumpkins and Halloween and breast cancer. So ghosts and goblins don't scare me. I survived breast cancer. So that's for all you ladies watching. So, so thank you so much for allowing me the privilege of being able to speak to you. I hope that what I've provided was some useful information, something that you got something out of. If you have any questions for me that come about later after the talk, my email here at Summa is gulotta@summahealth.org. Please feel free to email me. It's gulottaK@summahealth.org. And with that, I think if Gina knows of any questions now, I will I don't know how to pass it over to you, Gina. So
No, you got it. And we're joined by my kitty cat. He says hello. Remember, if you have any questions for Dr. Gulotta, please enter them in the chat box. I have a question to kick us off. It's actually twofold. Is if women who are survivors or men who are survivors are looking for places to go to get information on research, where would you recommend that they go? And when they're looking at research studies, are there any key things that you would advise them to look for, like sample size or who's funding the research, that may indicate any sort of bias in the research? Anything you could offer in that regard would be great.
Definitely, that's wonderful, wonderful questions. So I think two places that are really useful is number one, it's very technically minded, but they just have such a good wealth of information, is considering subscribing to just the emails potentially for the Annals of Surgical Oncology. I think that the articles published there are really great, and it's just a great resource. Additionally, there's a nice little page on the NIH website that kind of describes, new updates in breast cancer research, and it's something that's very palatable. It's like a little paragraph that you can kind of go through and read. And when you're looking at something that's more of a paper, like a publication in the Annals of Surgical Oncology, for example, I think Gina asked a really good question. Looking at sample size of patients is key. If, in some of the studies I mentioned, it's not a huge sample size, so that's something that limits us. But, the larger the sample size, the more we know that the conclusions are applicable to a broader group of women, a larger group of women. So looking at that, and also, looking at the funding for the studies and ensuring that this isn't one particular, pharmaceutical company that says, this is my wonderful, awesome pill. And, and it may still be an awesome pill, but just having that, in the back of our minds is always important.
Great, thanks for that. I'm not seeing any questions coming through in the chat box or on Facebook. I'm trying to monitor both, which is,
I'm impressed with just you monitoring the questions.
But so far, no one has any other questions. I guess I will ask, for those who are a couple years out into their survivorship in regards to research, are there anything in particular? I know you talked a lot about the recovery from, post-surgical, but many of our survivors are beyond surgical intervention. So do you know of any research that looks at long-term issues that survivors could face down the road after surgery?
I think something that is more and more being implemented now based on research in many breast centers is something called bioimpedance spectroscopy, which is kind of a big fancy word for a machine that looks at the water in our body and does really nice measurements. And what that's really useful for is really early detection of lymphedema. So obviously lymphedema is one of those things that we, it's just annoying. Nobody wants to deal with it, and no one should have to deal with it. So what the bioimpedance spectroscopy can do is actually it can help us detect lymphedema that wouldn't have been detected otherwise based on, kind of subjective feeling, or even just by, our measurements about 10 months earlier. So we have a 10-month head start in getting aggressive physical therapy and whatever treatments may be needed to reduce the symptoms of that down the line. So I think that's probably, if I had to say, I think that's maybe the most useful sort of new thing. And then as far as overall, survivor kind of facets of care and ways to avoid recurrence, the four things I always say are getting physical 3 times a week, making sure you get some moderate exercise, limiting alcohol weekly, no smoking, maintaining a healthy BMI, and trying to maintain a plant-based diet. So I think those kind of key things should hit most of the really, the daily kind of things that can affect survivors.
Well, and speaking of plant-based diet, the session that we hosted last week was all about getting supplements and vitamins through nutrition. And I believe the nutritionist we had on called it the kitchen pharmacy. So if anyone wants information on diet and how to, maintain that post survivorship, that session was recorded, also on our website, also on our Facebook and YouTube pages. So thanks for that. I'm not seeing any other questions come through. So I guess we'll just conclude a few minutes early, give you back a little bit more of your Saturday afternoon. It looks like the sun is wanting to come out outside, but
it's straining, it's trying, I don't know.
Yeah. But we'll give you back some minutes of your day. Thank you so much, Dr. Gulotta, for sharing this information.
Thank you so much for having me. Thank you.
So happy to have you. Always great to have Northeast Ohio represented in these conferences. So thank you for that. Again, these sessions are recorded, will be posted on our website within 24 hours and is now currently living on our Facebook page. So with that, I will tell you all to stay happy, stay healthy, stay 6 feet away, wash your hands, wear a mask, still go get your annual screenings. We really want to push for that. I had a mammogram back in May. Quite honestly, the hospital was the safest place you could possibly be with all of the protocols they have in place, taking your temperature, everything is sanitized, everything is socially distanced. So there's nothing to be fearful of COVID-wise with that. So go keep getting your screenings and encourage others to do the same. And with that, we will say good afternoon and thank you all for joining us.
Thank you, Gina. Bye-bye.
Bye-bye.